Hello, my name is Aline Guerin, here to present my Change project. Why are we here? In my hospital, when we do interventional radiology, most of the cases default to femoral access instead of radial access. In my Change project, we will encourage our interventional radiologists to do radial access first instead of the femoral access. It will be physician-led, nurse-driven, and which will improve patient outcomes. The big idea of my project is to have the IR doctors adopt a culture of radial access first whenever they pursue any procedure that involves vascular access, and empower IMC nurses to provide care that results in a better patient outcome. In my hospital, from the IR department, the patient goes to IMC to recover the post-op care of the IR patients. Here, the patients will have, ideally, will have radial access with radial compressive devices and will have a better patient outcome. To achieve that, for my Change project, I developed the patient pilot question, which would say, for patient in post-operative interventional radiology care, how do radial access compression devices compare to femoral arterial compression devices in reducing vascular complications during hospitalization? This will show that between radial compression devices versus femoral compression devices, the radial compression devices will have better patient outcomes over femoral compression devices. In my literature review, I have researched that with the radial compression devices, it has shown in the recent years that I have researched that radial devices have lower bleeding, lower vascular complications, better quality of patient recovery, and reduced hospital costs, versus the femoral compression devices having the IR doctors must communicate clear post-procedural monitoring and nurses documentation. Patients are on bed rest, head of bed has to be at 5 degrees or less, and are instructed not to bend the affected limb and hip and knee. Post-procedure care can last from 4 to 8 hours depending on the femoral site and doctor's orders. Nurses, such as me, are well familiar about these doctor's orders and how the patients are with the femoral site to achieve hemostasis. We are very familiar of how hard it is for the patients having the femoral access to achieve the hemostasis, having a femoral site, versus radial access, where the patients are able to sit up and even have a drink of water, versus the femoral site. Of course, having to achieve the femoral site, there's always risks and complications such as arterial occlusion, hematoma, pseudoaneurysm, arterial AV fistula, or the arteriovenous fistula, compartment syndrome, nerve damage, local infection. That is why the patients are sent to IMC to recover and not in med-surg floor. The benefits of why we pursue the radial access and the use of radial compression device, as I have mentioned prior, is that of patient comfort. Patients really based on a lot of nurses, including me, is of comfort that they go to the wrist or in the arm, and that they can sit up and not be laying flat for 4 to 8 hours. And of course, if not restricted by the doctor or of their physical attribute, they can sit up, maybe ambulate to the bathroom, maybe, if not restricted. And of course, they can have PO intake. They are not going to have a steak at that moment. Water, juice at that point. One of the things that is driven with the radial access is they are very adaptable to our obese population. It is very accessible for achieving hemostasis. Now, we mentioned earlier about reduced hospital costs because doctors in the discharge order, we can achieve as early as less than 24 hours of discharging home. It is achievable when it is safe. Always patient safety. The goal of the change, where from femoral site to the radial site, is the use of radial compression devices. In my hospital, there are a lot in the market. The popular one that's used in Las Vegas is the TR band. When our doctors are leaving the radial active first, the post-operative care orders will be radial access vascular compressive devices for hemostasis of the arterial axis. Such vascular device will come with parameters along with what their product recommends. And that is what the change project will really come into. The model of framework this change project will work on revolves around the interpersonal and cultural responsive care, where we work on the providers, the nurses and the doctors, provide a sense of trust. We work in the sense that the patients will trust us, that we are there for them. The other model of framework is a collaborative and interprofessional care models, where the rest of the team providing care are working together for the safety of the patients. And for this change project, I would form a team for their expertise. Definitely I would have the radiologist, the radiology nurse, the IMC nurse. I will get a hold of the educational department to track the project change, and our administration to approve the project. The proposed timeline for the change project, I have the first 2 weeks for the creation of the committee members, where we will identify, or the identification of the committee members and their roles in the formation of the committee members. They will know and identify what their roles and what they will be doing, and for what their participation is in the project. On the 3rd and 4th week, this is crucial because they will be creating educational tools, the policies that will be used for the 5, 6, 7, 8 weeks, where a group of people, which we will call the trial team, will be used for before we go to the 9th week for the rollout of the actual project. And then on the 4th month, it will be implemented hospital-wide. I came up with this project assessing my hospital's strengths, weaknesses, opportunities, and threats. When I thought of this, I looked at my hospital's strengths and I identified that my co-workers are skilled and licensed workforce. I have identified that most staff have more than 10 years experience and most of them have bachelor's degree. And amongst the workforce, there's good camaraderie in the staff. Opportunities, there is an ongoing new trauma unit and there's a proposed IR suite coming up. As far as the weakness, that is where I identified that the doctors will have to have or to adopt the radial access first. That way, they do not default to using the femoral access when performing IR procedures. One of the threats that I have identified is when the patients are not satisfied with the customer survey. That is how we should be addressed. As nurses, this change project is important because there's 3 governing factors that makes us licensed individuals. There's the scope and standard of practice under the American Nurses Association. There's the State Nursing Act under the Nevada Board of Nursing. And there's the Code of Ethics under the American Nurses Association. Scope as the standard of practice states that it outlines competence, it encourages the use of best practice to promote safe and effective care, it emphasizes health promotion, risk reduction, and early intervention to improve health outcome, and it clearly defines nurses' responsibilities. The Nevada State Nursing Act defines legal scope of practice, licensure requirements, and disciplinary procedures, ensures nurses' operation within their training and expertise, and protects the public by holding nurses accountability as a licensed individual. The ANA Code of Ethics is the code of ethics in nursing. It is patient-centered, culture-sensitive, and it prioritizes the public's welfare, rights, and dignity of patients. What does this mean? When we talk of competence, that is the standard of ethics where it provides evidence-based knowledge and resources to nurses and augments their nursing skills in post-op care of IR patients with radial compressive devices. When it talks about legality, that is where the Board of Nursing of Nevada ensures nurses that the post-operative orders will comply with the State Board of Nursing regulations and aligns with legal public health priorities. When you talk about ethics, that is the Code of Ethics under the ANA, which performs evaluates with sensitivity to ethical consideration legal mandates. What I can talk about now is have a case study. Say a normal one, no complications at the moment. Say we have a 45-year-old male, smoker, he is obese, comes into ER complaining of short of breath, chest pain. We do a lab work and it shows elevated troponin. Then we take the patient to IR, we do a angiography. It shows no blockages in the IR notes, and that's what the IR note says. In recovery, which is in the IMC, it has a TR band. Discharge order says home, and follow up with the primary. This is where the nurses, the nurse driven comes to assess the patient, follows all the what our team would form in the bundle that will be created, follows what the protocol we can create according to what our team will be able to build, according to what the standards created by the radial compressive devices, follow what the brand says is suited for our device, and discharge home to follow up the primary. If our goal is to discharge less than 24 hours, that would be possible. The evaluation of plan can be achieved every 3 months, every 6 months, just to get the opinion of the rest of the staff in the hospital, amongst the nurses, amongst the laboratory personnel. That way we can continue the quality of our process and get the opinion of the rest of the staff. Thank you very much for listening to my project.